All right. Good morning, everybody. Thank you for your patience with me while I was out last week. Couple things. I'm working on your exams today. I hope to have them all graded and your grades recorded by tomorrow. Just another heads up. I am going to record today's lectures and we'll post it later on today for you to use. Did you run into any problems with the exam? Any issues or anything like that? Okay, good. Everybody should have gotten an email from me about your midterm grades. I'm still not 100% confident in my ability to that the grade that you have on Canvas right now is an accurate grade. So that's why I recorded, just so that I don't get in trouble with the university. I recorded a C for everybody, and I'm going to do a manual grade with an instructional designer later today. And I will email out what your actual midterm grade is. Now, it won't change off of your midterm report, but remember, midterm grades mean nothing as far as your permanent record goes. It's just kind of saying, okay, this is where you're at. We're halfway through the class, and this is where we're at. All right. Any questions for me before we get into atrial arrhythmias again? All right. So let's talk about PSVT. Okay. PSVT is known as paroxysmal. Okay, come on, remote work. There we go. Paroxysmal supraventricular tachycardia. Now, the word paroxysmal means a sudden start and or stop. Okay, sudden start and or stop. So a couple things to remember about paroxysmal supraventricular tachycardia is that it is faster than 140 beats per minute. Anything up to 140 we can consider as being what rhythm? Sinus tachycardia. Excellent. Sinus tachycardia. All right. That's the key thing to remember. So when it hits 140 or higher, it's no longer coming from the SA node, but it's coming from somewhere else in the atria. With paroxysmal supraventricular tachycardia, and you can abbreviate this as just simply calling it PSVT. That's what I always do. You can either see the rhythm start sudden, and it'll be a sudden start or a sudden stop, or you could see both of them as you're looking at your rhythm. Now, the key thing to remember here is that PSVT is frequently seen in young people, but it can occur at any age. And in particular, what brings on PSVT, the two big things are going to be stress and caffeine. This is why about the end of April, the beginning of May, EMS will often see an increase of running calls on campus for this very thing. Why? Finals. Stress goes up, caffeine consumption goes up, and ultimately results in some people having this. Now, again, and I'm not going to criticize you for caffeine use because I live off of caffeine, but be really careful because, again, there are, so for example, if you were to go to Amazon, you can buy powdered caffeine right now.
Really?
Oh, yeah. Don't do this, okay? There was a student up in Ohio several years ago getting ready for finals, and he would snort caffeine. Perfectly legal drug, but it killed him, okay? And this is what happened to him. He overdosed on caffeine. Yeah. So again, just kind of keep in mind that anything that sets off the sympathetic nervous system is going to cause an increase in your heart rate. Now, let's think about this for just a little bit. Somebody, you become the teacher and I'll become your student. Somebody teach me, remind me, what does the word preload mean?
the amount of blood made available to the heart. I worded that much better last time.
That's perfect. That's perfect.
Blood that enters into the
excellent. Braden, anything you want to add to that? Okay. So let me ask you a question. If we start out at a heart rate of about 80 and we bump that up to 100, what's that going to do to our preload? Is it going to increase it or decrease it? No, it's actually going to increase it. Because think about it now. If we start out at 80 and we bump it up to 100, we're making more widgets. So the heart is pumping faster. All right. And so we're getting more blood that's going out, which means we've got more blood coming back. Now, you guys are smart. You're actually getting ahead of me. If we were to bump that up to, say, like 150, now our preload is going to go down, resulting in a reduction in cardiac output. Why?
Refill time.
Yeah, so the heart is pumping so fast, okay, that it's not open long enough for the blood to be able to get in, okay? And remember, the heart can't pump out what the heart does not take in. And so when our preload goes down, our cardiac output also goes down. And this is why it's critically important that with these patients who have PSVT, especially if you get called for them, they're going to be having some symptoms. And we'll talk about these in just a minute. So basically, well, we'll talk about them right now. Let's go right down in here. With patients that have PSVT, they could potentially be suffering from angina. Angina comes about as a result of chest pain because of what? My EMT should know this.
Angina is what?
Yeah, angina, yeah, whichever way you want to pronounce it, it's okay. So why would PSVT result in chest pain for our patient?
Is their heart beating fast?
Okay, that's part of it. You're exactly right. So the heart's beating fast. Close, but not quite. Say it again. One more time. Can I get an amen? There you go. Perfect. Yeah. So we're getting lack of oxygen. Remember, the heart is a what? Muscle needs what two things? Well, it needs oxygen delivered by. Okay. Oxygen is going to be delivered by blood flow, but it needs glucose. Remember. Okay. I mean, it's like 11:24. You guys are going to start getting hungry if you haven't already. So again, the body has to have that replenishment of glucose every now and then. So exactly what you said is what happens. Remember, oxygen delivery is also dependent on cardiac output. Cardiac output is also dependent upon preload. Preload is also dependent upon heart rate. It's the old song, the ankle bone's connected to the leg bone's connected to the knee bone. And this is everything, this is the way the body is designed. Everything is interconnected into each other. So again, when the heart rate goes up really, really fast, now we get decreased oxygen going to the heart. Where else do we have decreased oxygen going to? The brain. Yeah. Okay. Going to the brain. Now, riddle me this, Batman. If we have decreased oxygen going to the brain, what might your patient look like? Potentially cyanotic. Yes. That's going to be a late sign, but yes, that would definitely be one. What did you say? Confused. What else? Pale. What else? Eventually they're going to pass out. Sweaty. Okay? The medical term for being sweaty when it's diaphoretic. So it's kind of like, okay, it's 20 degrees out, patient's sweating. That's diaphoresis. So again, that altered mental status in particular is often the earliest sign that our patient doesn't have enough oxygen going to the brain. Now, file this next statement away in the back of your brain, but keep it close. Anxiety is often an early indicator of decreased perfusion to the brain. Okay. Now, anxiety can be a completely normal reaction to something that's scary that's going on. Okay. Your heart rate suddenly kicks up to 160. It's kind of like, what's going on? I don't know what's going on. I'm scared. What's going on? I'm anxious. Or it could be the fact that we don't have enough oxygen going to the brain. And so that's the thing we want to kind of keep in mind. So again, with these patients that have PSVT, and again, the higher it goes, the less likely it is that we're going to have enough perfusion to the brain. Now we're going to run into a major problem. Now, let's talk. First of all, let's look at the steps here, okay? And then we'll talk a little bit about one way that we may be able to address this, okay? Now, this says the rate will be 150 to 250 per minute. That has changed. Anything above 140 is going to be considered an SVT, all right? Now, just hold on to that. The rhythm is usually going to be regular with the exception of in PSVT, it will be irregular where it has that sudden start and or that sudden stop. So like in here, we see coming across on this side over here, it's going really fast. And now look at this. All of a sudden, we get what I call are some FLBs in here, funny looking beats, because these look a little bit like what is in here preceding. This one and this one do, but they're much taller, and then this one looks completely different. But again, this part in here is the irregular part, okay? The P waves, if you get a heart rate of above 140, you will rarely see a P wave. Why?
Like the QRS is going so quick, it's covering.
Yeah. So it is buried in the previous QRS. So as we're looking at this right here, okay, so as we take a look at this right here, you might be able to make an argument that that is a P wave, maybe. But I would tell you within this rate right here, I would probably tell you I'm not really seeing anything that I would want to hang my hat on to say that this is a P wave. So most definitely once it hits over 150, you're almost never going to see a P wave. They're there, you just can't tell, okay? Now, how can I come right to you? How can I be relatively sure that there is a P wave in PSVT? These patients could be unresponsive. So go ahead. Of what? Can't see it. If you can't see it, you can't measure it. I don't have P wave, you don't have PRN. Nope. So we're going to look at our QRS. If our QRS is of a normal width, that tells us that it's coming from somewhere in the atria. Now, this is borderline that we see up here as far as width of the QRS. All right. But again, if you have a narrow QRS that says it's coming from the atria, and even though we don't see a P wave, we're relatively sure that there is a P wave in there. It's possible that we could see a rhythm that doesn't have a P wave and it could be coming from somewhere else. But again, that narrow rhythm is what we're going to look. I'm going to go here and then here.
I'm having difficulty. is there maybe a rule of thumb for how high a positive deflection has to be for it to constitute a P wave?
No, there isn't. So, for example, let's take a look at this. Here's one of the things that you got to remember. Sometimes, much like life, you're going to look at life and you're going to go, well, this is this way. And I may look at the exact same thing and go, I just don't see it. I think it's that way. And both of us could be right or both of us could be wrong. Okay? There are sometimes, not always, but sometimes we will look at a rhythm and we'll say, oh, I think it's this. And you may be right. And I may say, well, I think it's that. And I may be right. Or we could both be wrong. One of the running jokes is if you put 5 cardiologists in a room and give them an EKG, you'll have 5 different interpretations. All right? Now, here's the thing that we're looking at. Remember, the P wave happens prior to the QRS. Okay? A normal P wave is upright. Now, you could potentially make an argument that that is a P wave. Okay? This one right here. But look at that one right there. Okay? So that changes. And then we have something here that looks even more like a P wave and a P wave and a P wave. So in this situation, if you see P waves within this, I'm not going to dispute it because, again, as long as we get to the end result of where we would need to be at, calling this PSVT, we're 2 thumbs up. We're okay. Does that help, Ethan?
It does.
Okay.
So I was just thinking, that's like, if we were going through this rhythm, we go through all the steps, we'd probably assume it's PSVT, but then if we get to the QRX complex and it's wider, that would be just a different rhythm.
That would be a different rhythm we have not covered yet, but we're going to get to it. That would be, again, previews of coming attractions. If your QRS is wider than 0.12, it is most likely coming from the ventricles. So just hold on to that, and we'll talk about why it would most likely be coming from the ventricles in a couple of weeks. Good observation. Good observation. All right. So again, if we don't see a P wave, we don't have a PR interval. The other thing we look at here is that, again, let me enlarge this for us. So in particular, if we look at this and we say that these are our P waves, do they look the same? No. So,
What is this on arrhythmia? Isn't this a rhythmic beat?
oh yeah. Well, everything that we're looking at is considered an arrhythmia. But again, if we've got 3 different P waves up in there, what could you potentially make the argument that this is? Mm-hmm.
Oh, it's the same thing.
Perfect. Yeah. Multifocal atrial tachycardia. Except what?
We've got those long.
We've got these over here. So we have this paroxysmal period. And what else? Mm-hmm. You're right. So we have a regular rhythm over in here. Most of the time with WP, we're going to have a bit of an irregular rhythm. Very, very good. But now it does get irregular over in here. But again, the rate. Generally, what we're looking at with a supraventricular tachycardia, we have 2 types. We have just plain SVT, and then we have PSVT. We're looking at PSVT first. But basically what we're saying is that the rate is too fast to be coming from the SA node. So again, if you wanted to make an argument on this, that this was MAT, we'd have a discussion about it, okay? And if you could explain to me why you think it would be, I'd probably give you credit for it. But in this situation, this one looks like more so to be PSVT. All right. Does everybody understand what the yes?
Is there a point with MAT? Like, is there a range that it stops at with that high rate?
Yeah, generally at about 150, it changes over from an MAT over to an SVT or PSVT. Why? Somebody in anybody, why would it, as the rate goes up above 140, 150, we would no longer really call it MAT? Well, yeah, but we're not entirely sure of that. It's definitely coming from somewhere in the atrium because the QRS is narrow. But why would we call that? Yeah, we can't see the P waves. I love being around smart people. Y'all are awesome. So, yeah, we can't see the P waves. So that's why it would change over to a supraventricular tachycardia. Supraventricular just simply means above the ventricles. Yes.
So, I'm sorry, I'm diverting a little bit. Proximal would be sudden, rapid.
Paroxysmal sudden start or stop.
Supraventricular, supra being above the ventricle.
Uh-huh.
So the atrium?
Yeah.
Why don't they just say atrial?
Some people do. Some people do. It was at one point in time, this was often called atrial tachycardia. The nomenclature has basically changed now to just simply call it either SVT or PSVT.
Okay.
And we'll talk about the difference of those in just a second.
And in terms of the actual what you're looking at, so PSVT versus SVT, are we going to have these periods of sudden arrest? I mean, how would you determine this from being sinus arrest?
So the
Besides
big difference between PSVT and SVT is that's what you see right there in SVT. Okay, imagine that is a 6-second strip. That's SVT, supraventricular tachycardia. You don't see it start or you don't see it stop. It's just fast. With PSVT, this is what you see. It comes in, we're printing it off, we're sitting on our monitor, and it's just beep, 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 beep. And then we start over here, and it suddenly slows down. Paroxysmal means sudden. Okay? So we have a sudden start and or a sudden stop. So you can actually, when you're watching this over the course of time, you'll actually see the start and the stop of the patient going through here.
Because I would honestly look at that there. That's probably artifact.
No, nope, that's not that. This right down in here could potentially be artifact, but it's probably not because again, you got to look at the whole patient as far as when you're going through here. All right. Now, let's talk about SVT. Hold on. All right, come back here. All right, supraventricular tachycardia. The causes for SVT are the exact same as what we would see for PSVT. Okay, the exact same that we would see in there. Basically, the big thing. Hey, perfect. Thank you. So the big thing that we're looking at here with SVT is again a drop in cardiac output. Why?
Because it's beating.
It's beating too fast. So the actual open period where the heart can receive blood is too short. That's where our preload comes in. And as a result, look at this. This is the same slide that we had a minute ago. Angina, hypotension, congestive heart failure. Okay? Now, look at this right here. That's SVT. Do you see a P wave? And don't tell me that's a P wave. Because it ain't.
It's too close to the QRS.
No, that's far enough away from the QRS. That's a T wave. That's a T wave. But if I go ahead. Let me enlarge that. You can make. Does it look like a P wave to you? So you could make an argument that that is a P wave, but that's still not going to change. That was the door that locked. That's still not going to change the fact of the rate. Okay. So again, down on the lower end of SVT, we may begin to see. Oh, I bet that's Braden. Sorry about that. They're out there doing they're out there doing a lab. So again, the thing that we're looking at here is that it is definitely going to be fast. Okay. So now, ladies and gentlemen, boys and girls, tell me again, what's the difference between PSVT and SVT? Sudden onset or sudden termination. And if you watch it long enough, you'll see both of them. Yes.
So, could you have a normal sinus rhythm that goes into PSV?
Absolutely. Absolutely. You have a sinus bradycardia that goes into it and then out of it. Normally, what will happen is that it will convert into, let me back up here. I mean, you can have a sinus tach that moves into an SVT. And if you see it start, then we call it PSVT. All right. Now, again, here's where we're going to talk a little bit about treatment. Okay. There's multiple ways that we can treat this. Well, first of all, we have to decide simply because we can treat something doesn't necessarily mean that we're going to. Here's the thing, ladies and gentlemen, it's important for you to remember. Assess your whole patient that is there in front of you. Don't look at this and say, oh, heart rate's 150. Bill said to give them this. Bill said to do this. Bill's not saying anything at all like that. What Bill is telling you is to don't just look at the monitor. Look at your patient. When you're assessing a patient, how do you know, we're going to take the opposite extreme here, or the opposite view. How do you know if your patient is stable from a hemodynamic perspective? Which would be what? Pink and dry. Very good. What else? Mental status would be good. Blood pressure. Excellent. What else? Their breathing rate is normal. What else? Now, we can have an abnormal heart rate and our patient still be stable. Okay. What else? Because you can keep in mind, you can have a really slow heart rate and the patient be stable, or you can have an elevated heart rate and your patient be stable. Okay. Again, that's why we always say treat your patient, not the monitor. O2 sats are good. All right. Say it again. End-tidal CO2 looks good. Yeah, you guys are you got it. So yeah, again, so we're going to look at all of those and we're going to take all that information in. Don't treat your patient off of one assessment finding.
So what you're saying is that we should administer any sort of treatment if we don't deem it necessary for the risk. Like if we,
that's part of it. Yeah, here's the thing. Everything that you do as a paramedic, everything I do as a paramedic, has a potential risk. Now, there's three things that we can do in this situation if the patient is not feeling well. And understand that there's different degrees of instability. You have the patient who may be having a heart rate that's really, really fast. It's just kind of like, man, I just feel tired. I am so tired. Okay. Or you have the patient who says, man, I'm so tired, my chest is killing me. Or you have the patient who says, I'm so tired, my chest is killing me. And now they're beginning to get a little lethargic. It's kind of like they're slurring their words. They act like they're sleepy and things like that. They're degrading. They're going down. They're going down that path. So one of the things that I want you to learn today is that how we treat this is that it has several different names. Yes. Now, what you've done is what I like to call you've gone to the nuclear option. That is a tool in your toolbox. But again, one of the key things to think, and I love the way you're thinking and your experience is showing. That's awesome. One of the things to keep in mind is that you got multiple tools in your toolbox. If you want to tighten up a bolt on a nut or put a screw into a piece of wood, we're not going to pull a hammer out, okay? Even though you might be able to make it work, it wouldn't be the appropriate tool. Cardioversion or electrical therapy is most definitely a tool that you're going to learn about. You're going to learn about it in this class. But what we have to do is we have to determine. That's why I said we want to determine, first of all, is their patient stable or unstable? If they're unstable, how unstable are they? And again, when we're treating our patient, we want to go with the least invasive, most appropriate action for how that patient presents. Excellent.
Bearing down Vegas. Okay.
Coming to that. Excellent. Hey. Absolutely. Well, it depends. How would you? Okay, so again, well, let's talk about the treatment for this. First of all right. So we got three potential things that we can treat, or three potential ways that we can treat. First way we're going to do is we're going to do a vagal maneuver. Sometimes you'll hear it called a Valsalva maneuver, name of a doctor. Okay, but a vagal maneuver. What does the vagus nerve do? Okay, and how do we activate Braden the vagus nerve, the vagal? Yeah. So taking a deep breath in and holding it, bearing down like we're straining to have a bowel movement. One of the ways you can do this is take a piece of tubing, cut it off in about a 1 foot length, have your patient blow through it. Give them a syringe, pull the barrel of the syringe out. This works great if you ever have kids with SVT or PSVT, of having them just try to blow the barrel of the plunger of the syringe out. And it builds up pressure inside your chest. When we put pressure in the chest, it blocks the development of acetylcholine, and the heart rate goes, slows down. Okay. This is one of the ways that what's called boxed in breathing, they teach us for people who have anxiety, who are going through PTSD, as far as to control their breathing. When law enforcement is going through active shooter training, they teach them how to control their breathing, because again, you go into a shooting situation, the last thing you want is kind of like this right here. You want it to be nice and steady. And one of the ways you do that is you take a deep breath in. So a vagal maneuver or Valsalva, we can do this a couple of different ways. Number one, we take a deep breath in and we tell the patient, hold your breath and bear down like you're having a bowel movement. Okay. Blow in through a straw. Blow off the end, the plunger end off of a syringe. All of those will do the exact same thing. It will build up pressure in the chest, puts pressure on the vagus nerve, and the vagus nerve slows everything down. Now, another potential way of doing this, and I would tell you that you want to start with doing the pressure on the vagus nerve, the vagal maneuvers as far as with breathing first, is that you can do a thing that's known as carotid massage. We have a carotid artery. The carotid artery connects to what as it's going back down this way? What does the carotid artery run off of? Braden? Huh? Uh-huh. The aorta. Okay, so in the heart, we have the aorta. It comes up and comes over this way. And as the aorta is going this way, we have two carotid arteries. One that comes up and one that goes over this way. When we put pressure on the carotid artery in here, that slows down the blood flow, which guess what? Causes a back pressure that reaches down into where the vagus nerve is. So we're in essence able to activate the vagus nerve by just simply putting gentle pressure. Now, don't strangle the person because, yeah, their heart will eventually slow down and stop because you've killed them. All right? But you just want to put some gentle pressure there and release it. Gentle pressure there and release it. Now, before you do that, this is critical. Take your stethoscope and you got to listen to the carotid arteries. The carotid arteries, under normal circumstances, probably for all of y'all, your carotid arteries are going to sound like whoosh, 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 because you're young. You haven't completely filled up your arteries with fat and cholesterol yet, okay? Don't do it yet, okay? If you were listening, my carotid arteries are clean, but if you listen to somebody of my age, their carotid arteries would often sound like there's plaque there. Basically, it's kind of like a river with a bunch of rocks in it, and it's crashing against those rocks. That's plaque. So why are we listening for? So what? The last thing we don't want to do is we don't want to put pressure on the carotid arteries and break that plaque off, because guess where it's going? It's going to the brain. And if we can cause our patient to have a stroke, that's not good. So again, if you hear, and that's called, you're hearing a bruit, B-R-U-I-T. Write that down. You'll need to know it. A bruit, B-R-U-I-T. That says that we've got some kind of an occlusion in the carotid artery that tells us we're not going to put pressure on it. Now, let me ask you a question. You're smart people. If I'm listening over here and I hear a bruit over here. Okay, Bill said don't press there.
Try the other side.
Should you try the other side?
Why not?
I don't know. I asked the question first.
Yes.
So Ethan says yes. Anybody take an opposing position? No, they both come up off of the aorta and they both go up into here. Now we've got jugular veins that bring the blood back down. Braden. Why? So there are other methods, but again, remember the body has a tendency to be symmetrical. So if we've got a brie on this side, you're probably going to hear a brie over here, but exactly what you just said, it's too risky. Even if you come over here and you listen and you hear a nice clean carotid artery, that's a no-go. Okay, so when you hear it on one side, that eliminates the other side as well. What's that?
The risk is just unnecessary.
It's just unnecessarily there. You're not going to use carotid massage a whole lot anyway, but you do need to know about it because you've got two other things that you can do. No, when you're checking, because remember what you're doing is when you check a pulse for either the carotid artery or the radial artery, we just barely want to touch it, because if you push it too hard, especially with pediatrics, if you push it real hard, you're going to occlude it and you're not going to feel a pulse at all. So when you're checking a carotid pulse, you're just barely touching it. We're talking about some pretty good pressure. We don't want to occlude off the airway. But what we do want to do is we want to slow down, or we do want to press it enough to where we're presenting some back pressure. Okay? Everybody clear on vagal maneuvers, Valsalva, same thing, and carotid massage. So you got two other things to do. We'll talk about these at length later in the semester, but I'll tell you what they are now. Second one is going to be pharmacological intervention. You're going to give a drug known as adenosine. Adenosine is my favorite drug of all times because it does all kinds of weird stuff. I can tell just by your grin you've seen it given. And so we'll talk more about that. The last treatment that we would have this is for, like I said, like you had talked about a second ago, is electricity. What we're going to do is we're going to shock this patient. That's the nuclear option, and it has to be done in a special way. But again, we'll talk about that probably mid-April. Yes.
Adenosine was the most invasive.
No. Adenosine is the nice thing about adenosine is that it has a half-life of 10 seconds. So when the patient begins to have uncomfortable side effects, they're gone in less than a minute. Okay. All right. Are we good on? Yes. We'll talk about adenosine later on. I don't want to get into the treatment just now because I want to make sure you got a good foundation of identification first. But the short answer is no. We give 2 doses. All right. Any question on SVT and PSVT? All right. Atrial flutter. Okay. Atrial flutter is basically what is happening. Let me back up here. Let me enlarge this just a little bit. Okay. So, tell me what you notice about these things right here.
Appears like there's 2 T-waves.
Actually, there's 3. This is your T wave right here.
Okay.
What else do you see? They're symmetrical. Very good. What else do you see?
Good QRS.
Okay, just about these waves in here. But you're exactly right. The QRS is fine. What else do you notice about these? What do they look like? For example, what? Not the ventricle. This is coming from the atria, right? They're round and upright, but they look like something else. What do they look like? Sawtooth or a picket fence. Okay? Remember, picket fence has kind of the white things up on the top there. But again, this is atrial flutter. So what is happening in here is that you've got a site in the atria that's going discharge, 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 and then it sends it on through to the ventricles. Okay? And then we go back and it does it again. Discharge, discharge, discharge. And then it sends it on through back to the ventricles. Okay? Now, these are not called P waves. These are known as big F waves. Okay? Big F wave. Be careful how you say that in mixed company. Okay? Non-medical people will think you're saying something entirely different. But again, atrial flutter is where the atria will fire multiple times before one of those impulses will now go down in through the ventricles. Basically, what happens here is that the atria is diseased, and this you do need to remember, this bottom bullet right here. We see this quite frequently with heart failure. Okay, we see it frequently with heart failure. Why would we see it frequently with heart failure?
Your neurological pathways are compromised, or the tissue of the heart is.
The tissue of the heart is compromised. Because remember, with heart failure, the heart is not, and we'll talk more about heart failure later, but the heart is not working really well as a pump. If a heart's not working well as a pump, it's not putting out enough oxygenated blood. And guess what organ is the first not to get enough oxygenated blood? The heart.
When I hear atrial flutter and I see that EKG, I'm imagining, and correct me if I'm wrong, the atria is not fully contracting, it's twitching.
It is. Okay, now let's think about this for just a little bit. If the atria, if Ethan is correct, and he is, yay, even a blind dog finds a bone every now and then. But if the atria is not fully contracting, what else is not happening?
You're not getting full blood flow. Your blood pressure's going to be crap.
Not necessarily crap, but it will be. Yeah, which is doing what to our cardiac output? Which is doing what to our preload? You see how everything is interconnected here? So again, the other thing to kind of remember here, all right? Let's go back. Let me pull this up. Big F waves. Flutter waves is what they're called. Flutter waves. And we spell flutter with a capital F. Let's say, just for argument's sake here, ladies and gentlemen, that this is a 6-second strip. It's not. It's probably more like a 3-second or potentially even a 2-second strip. But let's say that it's a 6-second strip. What is your heart rate? Okay, good, Faith, excellent. So the heart rate would be 40. Let me ask you a question. What's your atrial rate?
60 to 80.
Well, you got enough up there to give me a number, not just a range.
I saw that it's normally 2 to 1 with it.
Well, with this one, it's actually 3 to 1. So basically what we're looking at here is our atrial rate would be this right here. So remember, Faith was spot on. Ventricular rate, 1, 2, 3, 4, multiply by 10. That's our 40. Okay? Look at this. There's 1. There's 2, 3, 4, 6, 7, 8, 9, 10, 11, 12. Atrial rate is 120. Atrial rate is 3 times the ventricular rate. This leads into the reduction in the cardiac output. Yes.
Is on that at the end of that last QRS, the one you skipped, is that because it's the T wave? Or?
This right here?
Yeah.
That's the T wave. Yes, sir. Very good.
So, but for all the other ones, because the T wave already happened. Right?
Yep, the T wave would be right over in here. Yeah, good catch. Good catch. All right. So as we're looking at this, again, remember it's in here. Okay. So now basically, again, we're looking at atrial flutter compromising cardiac output. Why? Because, like Ethan said, the atria is twitching. It is not completely contracting to empty out all the blood that it possibly can. Now, we'll talk in just a minute about its cousin, atrial fibrillation. You can have this that will go back and forth between atrial fib and atrial flutter. And we just simply call it fib flutter if you want to, or atrial fibrillation going into atrial flutter and back and forth moving on. Most of the time for your patient, they will be stable because the ventricular rate will be fast enough to help to make up for the decrease in cardiac output because of the twitching of the atria, right? Now, we're not going to worry about treatment on this for right now, but let's go through our 5-step process. Ooh, look at that. Let's say this is a 6-second strip. What is our ventricular rate there? 80. What is our atrial rate there?
$40, $130, $120.
Pretty close. Pretty close. I would say it's anywhere from like 280 to 320 as you're looking. Yes.
So you're just each flutter wave is 10. Like
Yeah.
the same principle.
So it's going to be the exact same principle because what we're doing is that we're seeing this in here and we're going to count each flutter wave and we're going to multiply it by 10 because we're looking at 6 seconds. So we've got an incredibly fast atrial rate. Now let me ask you this, ladies and gentlemen, boys and girls. Does it appear to you that the same site in the atria is depolarizing, or do you see multiple sites in the atria depolarizing? Say it again. So Faith says it looks pretty consistent. Anybody have an opposing position?
There's one deviation that I can clearly see.
Say it again, Abe. There may be. Okay, so when we look over at this one right here, this one's quite a bit smaller than these over in here. So I would tell you, again, in many situations, this is where it's kind of an interpretation. I would lean towards agreeing with Faith that I think most of the impulses of the flutter waves are coming from the same site. However, you do have an argument there, Abe, because some of these do look different. Okay. We need a longer strip. Okay. So we have a normal ventricular rate. We have an atrial rate that is really, really fast. Okay. In atrial flutter, the rhythm is going to be regular. Okay. Except when it's not. Okay, now let's talk about that for just a minute.
I apologize. Before you continue, could you please break down again how you achieve the atrial rate again?
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30, 31, 32, 33, 34. Multiply 34 by 10, and so your atrial rate is approximately 340.
Is that not a T wave?
It is so fast that the T wave is probably, this is one of the few times you'll see this, it's probably hidden within the flutter wave. We're not sure. But because this looks just like the others, I would classify that as a flutter wave.
Gotcha.
Good questions. Don't apologize for asking questions. That's what you pay for. Right? Keep those going. Now, one of the things that I want you to look at in this is, again, these are flutter waves. What's your PR interval? Say it again. Why not? You're right. You don't have a P wave, you have a flutter wave. There's no such thing as an FR interval. If you don't have a P wave, if you can't see a P wave, or if we don't call it a P wave, you have no PR interval. Outstanding. So that's gone. Our QRS is going to be of a normal width. Why? Yeah, it's not the ventricles. It's following the normal conduction. Now, one other thing to look at here. Remember I said that normally atrial flutter is going to be regular, except when it's not. What condition would need to exist to make this not a regular rhythm? You're close. You're really close.
Multifocal atrial tachycardia.
You are also very close. Think of it this way. Right now we have This is one other reason why Abe, I would say this is coming from the same site. They look the same. We got 1, 2, 3, 4, boom. 1, 2, 3, 4, boom. 1, 2, 3, 4, 5, boom. But that comes back to 1, 2, 3, 4, boom. Imagine if this was 1, 2, 3, 4, boom. 1, 2, boom. 1, 2, 3, 4, 5, boom. 1, boom. What would that do to our rhythm? It would make it irregular. Okay. Now, I want to let you in on a little tip. Here's how you earn a little bit of extra credit when you see rhythms like this. If you look at this rhythm right here as a whole, and you tell me, oh, that's atrial flutter, Bill. That is atrial flutter with a 4-to-1 conduction rate. First of all, if you tell me it's atrial flutter, and it is atrial flutter, you get full credit. Okay? But if you look at it and you say, oh, it's atrial flutter and it's a 4-to-1 rate, I will give you a 50% bonus on whatever that question is worth right then. If you look at it and you say, oh, it's 4-to-1 and it's actually 3-to-1, I'm not going to take any points away from you. You just don't get the bonus points. So it can only help you. It won't hurt you. The other thing to look at here is, again, if we're looking at this and it's 1, 2, 3, boom, 1, boom, 1, 2, 3, 4, 5, boom, how would we describe that?
Irregular. Atrial flutter.
Not quite. We would call that a variable ratio because you got like 3-to-1, 2-to-1, 5-to-1, 1-to-1. And that's the other thing that you would tell me. If you have this and it is an atrial flutter and it's irregular, and the best way to know if it's regular or not, count your R to R's. If they're the same, then you got to look down in here and tell me how many flutter waves you see for every QRS. Okay? Don't tell me that, don't write this down and say, well, this is 1 to 4. What you would tell me in that situation is you would have 1 flutter wave and 4 QRSs. This is 4-to-1. The opposite is not the same. So you got 4 flutter waves to 1 QRS. Then you get the bonus point. If it's variable, you just say variable ratio. Bonus. Questions? Yes? Look at the whole strip and come up with it based on the whole strip. That's the only section in there that has that extra little flutter wave. All the others are 4. So again, much like what we're doing when we're looking at, so when you're identifying a person, you're looking at the whole person to identify the person. Okay? You're going to do the exact same thing here. And it does indeed have 1 extra in there, but I would say for the rest of them, they're all 4. Good question. Anybody else? Brady. I would say this was 4-to-1 because, again, just like you said, we got this one right here. 1, 2, 3, 4, 5. That's the only one that really has 5 in it. Everything else appears to have 4. So that you go with the majority. Other questions? You look a bit brain dead now.